Welcome to the Texas Medical Association's Distance Learning Center. Timely, convenient, and affordable education from TMA, your trusted source for practice and professional needs. And now, the audio portion of our program.
Thank you guys for inviting me to speak to you. Today we're going to discuss using and understanding quality information. Having been on the payer side of healthcare as well as the TPA side, and then moving over to the provider-physician side, I can honestly say physicians are behind the times when it comes to information technology and data. So today we're going to go through, let's get out of this. Today we're going to go through a couple of things. We're going to briefly go through the claims workflow. And the reason being is because I want you guys to see how insurers are gathering information about you, as well as the patients that you're servicing. We're going to go through provider trending, exactly what they're doing with this data, how they're using it. We're going to go through data use for provider trending, as well as access to data, how you can get your data before the health insurer sees their data, how you can make sense of it and make better decisions within your practice before the insurer gets the data. We're going to look at a case study for a medical group in Illinois, and then we're going to make some determinations on what physicians can do now. So the first thing that happens, and we're going to go through step by step, the first thing that happens is the practice pretty much documents the episode of care. If you look at this slide, you can see you have all the subscriber information, you have all of the patient information. I've added a little bit more just so you guys can see once we get to talking about electronic claims. But you have the determining payer as well as the submitter, who your clearinghouse is. They have to put that information into the claim. Who the receiver, who the billing provider is, but most of all, getting to the patient information because we are documenting the episode of care. So the initial is this an initial visit? Is this a returning visit? What were the previous charges? What was indicated in the follow-up visit? What services were performed? Any charges, any labs? That type of stuff, as well as one thing that I left out, which is definitely key, and we're going to talk about that a little bit later, but the pharmacy aspect that comes into that. Total charges as well. So then what happens is the practice submits the claim information. One or two things. Either the practice is submitting their super bills to their biller or coder, or billing and coder organization, or they're documenting that information into their practice management system. A lot of times what comes along is when you guys are working with your practice management system vendors, the vendor may come out and get all of the EDI data or come out and get that data from your practice management system. And it gets uploaded nightly in a batch file or it gets uploaded every 48 hours, depending on how that works. It can take anywhere from a week to submit your previous super bills for the previous week and then go to the medical biller or coder for them to code the claims. I'll tell everyone, please submit claims in 48 to 72 hours after the episode of care, the date of service. So then what happens is it goes to the practice billing service. So basically what they're doing is they're coding and billing the claim. They're either scrubbing the claim submission data, which I encourage all of you who outsource medical coding and billing, make sure that they're scrubbing your claim data. Make sure they're looking at those edits. Make sure they're looking at the date of birth, as well as the male-female relationship or the sex relationship to the services that you perform. A lot of times the billing services now are so advanced where they're picking up the edits of the payer. So they know that this is not going to go through or this particular claim is going to be rejected. So what they're doing is they're sending that back to the practice before it goes to the payer. So make sure you do have a medical coder or a biller that's scrubbing your claims data for you. And like I said, they may review some of the known payer edits. The next thing is it goes to the practice clearinghouse. At this point in time, whatever that paper claim that may have been is now electronic. And so what happens is you have all of these claims. Not only does the clearinghouse have your claims from your previous week or your previous day's submission, but they have all of their other clients' claims as well. And this is what it looks like, exactly what it looks like in terms of electronic data, because this is how the payer actually picks your data apart. So just imagine thousands and thousands of claims going to the payer. And so once it leaves the practice clearinghouse, it goes to the payer's clearinghouse. So basically what they do is they receipt the claim, and then they sort it. Where does this claim need to go in terms of the destination? And then they extract they extract the claim to the appropriate adjudication platform. So what happens when it gets to the payer? So payers typically run a system of 4 checks. So first of all, they determine if it's a duplicate claim or not. That's the first thing any payer will do. Before it goes through their system, they need to know if it's a duplicate claim. There are some clearinghouses and some payers who are sending unsolicited 277s back. And basically what that is an EDI transaction that lets you know the status of your claim before you send the duplicate claim back. So at day 15, you haven't heard anything from the payer. They're typically submitting an unsolicited 277 back to your clearinghouse saying, hey, this claim has been pending for this particular reason. The next thing they look is to see if you fall on that fraud and abuse list as a provider before they touch the claim, or they'll look at it. They want to know if you're on that fraud and abuse list. The next thing they're going to check is eligibility of the patient. And then they're going to check to see whether the physician is in or out of network. All this is done before they adjudicate the claim. Sometimes, working on the TPA side, this may or may not happen. Sometimes the claim at that point in time, once it goes through the duplicate check in and out of network, some of the things that may happen is it may go out of the claim adjudication platform, or before it gets there, they may go ahead and reprice the claim. So that means that the provider group, whoever your contracting provider group is, it may go there to see what the contracted rate is. So what it's picking up on is your rendering provider, billing provider demographics. It's also picking up on your contracted fee schedules to make that determination. For out-of-network, rendering provider, billing provider demographics, and any previous discounts that you may have signed on board with. How many of you guys are familiar with Wrap Network? This is Wrap Networks. This is where they come into play at this particular level of payer repricer. So then what happens? Now we're at the adjudication process. So the contracted fee schedule for claim adjudication, they're looking at the rendering provider information, procedure codes, and bill charges. Any state mandates that may have for diabetic patients, preventative care, they're looking at those as well. And what they're using to make that determination are your procedure codes that were submitted, diagnosis codes, patient information. For pricing edits, which you can say, they're looking at the procedure codes, diagnosis codes, patient information. And then any payer-specific edits, those black box edits that you don't know about until after the claim is either adjusted or denied, they're looking at the procedure codes, diagnosis codes, and patient information. So what does all this mean? We're going to take it one step further, and we're going to talk about what happens when it comes back into the practice, and then we're going to talk about a little bit of what they're doing with the data and how they're using it. So what happens is once your explanation of benefits comes back into the practice, or the electronic remittance advice and or payments, I will say that, you have a couple of things that you definitely can take a look at. Administrative information such as payer claim receive date. How many of you guys know that you want that information coming back into your practice? Why do you want that information coming back into your practice? Because it's going to let you know if they owe you interest. Okay? A lot of times you submit your claim to the medical biller or coder, then it takes another couple of days to get to the clearinghouse. Then you have no idea of when it actually got to the payer. So them returning this date back to you lets you know whether you fall within the 14 days of clean claims or not. So this is really key. Another thing is the allowed amount. How many of you are getting that information back? You send your bill charges, you know what your contracted fee schedule is, but the actual allowed amount. I guarantee you if I went around this room and asked everyone what their definition of allowed amount is, most of us, because I'm talking to physicians and not payers and clearinghouses, most of us would be on the same page. However, when you ask out in the industry, we definitely have different definitions of what allowed amount is. I will say that one of my other things that I do besides helping providers is I actually advocate for providers as well. So basically the standards that are written to exchange data within healthcare, I advocate for these types of fields to come back in your electronic remittance advice. Because if you have these things, one of the things you can now do is automate. Things that you manually process or that your staff manually processes, we can now begin to automate within your practice management system. So that's why these fields are key. We give them all that information about on the 837 about the claim and the episode of care to get reimbursed. We barely, from the physician side of it, get back 45% of what we give them, if that. So these are things that they say when they write the standards, because I'll be honest, it's just 10% of physicians or providers around the room helping to write the standards. One of the things we do is we advocate so that these things can come back. And so they're not situational, that they're actually required to come back. Network name, uniform payer identifier, claim status code, check issue or EFT date. Why is that key? That's key because a lot of times, how many of you guys get the the electronic remittance advice, and the EFT follows 3, 4, 5, 6 days later? How does your staff know when it's time to reconcile the claim? Because technically they can't reconcile until the payment comes back into the practice. So knowing when, at least haphazardly knowing when that date might fall, that's definitely key so that your staff can definitely go back and say, hey, the EFT did come in on about this date. I can actually go back and now reconcile this claim. And then if all this information is coming back, it doesn't have to be manually done. It can be automated. One of my favorites, or 3 of my favorites, are claims adjustment group codes, reason codes, and remark codes. These are codes that are given for denials and adjustments. So what happens is anytime a claim is adjusted or denied, you have a claims adjustment group code. Is it patient responsibility? Is this claim adjusted or denied due to contractual obligations? What is a more specific reason? Deductible amount, non-covered services. And then the remark codes add a little bit more specificity with that. So when these things are coming back on your claim, and your system is picking, or your practice management system should be picking up on these things, and one thing you can do is begin to automate. I know when I see this that I must bill the patient. I know when I see these group combinations, I must write it off. I know when I see these combinations, I should go back and actually look at my contracts to make sure they reimburse me correctly. I know when I see these particular combinations that I can actually, or I need to send an appeal letter. And I need to send an appeal letter for these reasons, or my appeal letter should state this. So these are definitely things that are key. When you guys are out here looking for practice management systems, make sure, I would probably start this slide, because you want to make sure that the practice management system has the ability to hold this data in your practice so that you then can begin to automate. Everyone always asks me, what's the best practice management system or the best EMR out there? I'll tell anybody, look at your specialty, look at your practice, find out what I won't say wasting time, but find out what is consuming the majority of your administrative time for manual processing. You want to look to a vendor that's going to automate that process for you. So provider trending, what are they doing with the data? We already know how they're getting the data. They're getting all of this data through physicians' claim data, but what are they actually doing with it? So they're using it for your contracting terms. How many of us don't know that? They're using it for RAC to determine if you are within fraud and abuse, or if you are an outlier to other physicians who have your same specialty. Within your locality, are you performing more of these services? Are you performing less of these services? If so, why? Physician billing profile, including fee-for-service, they're looking at all of that information to be able to do that. They're building your physician quality profile. They know where you are before physician quality even became a big thing. They know that it's a possibility you may be an outlier to other specialties like you. Comparative clinical effectiveness. They're looking at it from a clinical outcome as well. So where are they getting the data? We know that they're getting it for the healthcare claims data. Over time, all of this, as Mary Jo mentioned, they're pretty much building a warehouse of billions and billions of claims. And see, the thing about it is payers have already had this. They've had this for I've been in healthcare about 15 years. They've had it over 15 years. Because they key this information. Believe it or not, it wasn't as automated as it is now, but they would have to key the information so that their systems could go through the logic to determine whether the claim should be adjudicated, if it should be denied or adjusted, or how it should be paid. They've always had that IT logic in place. It's just that now payers are having, I won't say payers, I'm sorry, providers are having to be hip or get hip to exactly what it is that the payers are looking at when it comes to claims data. So data used for provider trending. I can break this out again, and I've broken it out a little bit more specific. So what actually are they getting from the rendering, billing, provider information. They're getting your demographics, your locality, NPI TIN number as well, taxonomy code. How do you compare to other to other physicians who are using the same taxonomy code for the services that are performed? They're looking at the specialty. They're looking at what procedures or services that the physician is actually providing. They're looking at the bill charges. What are your bill charges compared to other physicians that are in your locality? Patient, they're looking at the subscriber demographics, and they also use a lot of this for underwriting as well from the patient standpoint. They're looking at the subscriber demographics, account numbers. What happens when the account numbers for this particular patient who has the same date of birth, same sex, same name, the account numbers are different. That would signal fraud. They look at initial visit, follow-up visit, as well as any copays. So then they're also looking at what's most important, the episode of care. What happens during the initial visit for the date of service, place of service, diagnosis and procedure, and bill charges. And they're looking at those same key things for the follow-up visit as well to determine if anything has changed, anything's different. I'm telling you, when I look at analysis and trending, payers have always had this ability to be able to do this. And now they're getting more tech savvy with it as well. So access to data, what does this mean? So what all this means is that physicians, let me go back. Oops. Okay, sorry, wrong way. So what does this mean? Mary Jo definitely showed a couple of dashboards as well. That means that you guys have access to the data really before the health insurer has access to the data. So I'll tell anyone, just as I mentioned before, when it's time to purchase your practice management system or your EMR, you want to look for the practice management system in EMR that's going to give you all this information. And not only are they giving you this information to be able to do your own trending and analysis to find out where you stand, you also want to pick a system that actually helps to reduce your manual rework. So you can see that these are just a couple of the dashboards, your patient revenue services, payments by office, payments by provider, especially if you have more than one physician in your practice. You want to be able to compare your physicians. You want to know who your physician outliers are ahead of time. So access to data. How do we get access to data? A couple things. So in your practice management system and your EMR, they're already giving you reports. They give you what we call canned reports or ad hoc reports. These are reports that can't be changed. The system just gives you these reports as soon as you click to go run them in the reports menu. And they pretty much are giving you your detail by physician, your detail by specialty, detail by patient, detail by diagnosis, detail by services, and the detail by the episode of care. What does all this mean? Pretty much printouts. It's nothing you can do with that particular, you can't do any trending and analysis off of a printout unless it's giving you a summary report. And like I said, a lot of those are canned or ad hoc reports. So when you're in the search for a practice management system or EMR, you want to make sure that it's something SQL-based. Something where you can extract this data, you can roll it up and create summaries, you can query it any way you want to, if you want to just pull out a specific specialty or pull out a specific physician. And you want to do this over a period of time. So these are the types of reports that you actually have the ability to do, but now we're going to take it a step further. Now that you have the reports, let's actually do some analysis and trending on them. Your billing clearinghouse reports, your claim rejections and denials, those are another thing. You want to make sure that your clearinghouse is giving you adequate data or adequate information for your rejections and denials. Just having the information does nothing but saying, hey, you know what, last month 55 claims were rejected because of this particular reason. Not, oh, here we have one claim that was rejected because of this. We have X claims that were rejected because of this. Let's just say, as a summary, 55 claims were rejected because of this. And guess what? We can go back and recoup those funds. That looks very different than having one claim at a time that was rejected for the same reason. Payer reports. Hey, they're running reports. They're running your patient reports. They're running your yearly service reports. They're running quality incentive reports. One thing that I did drop in here was ICD-10 based on claims history reports. Believe it or not, I'm also the co-chair for the ICD-10 Strategic National Implementation process for the Work Group for Electronic Data Interchange for WEDI. And one of the things that the payers definitely sat around the round table and they said, you know what, we're going to help the physicians out. Not sure if that's quite helping, but what they're saying is they're going to start to supply what ICD-10 would look like based on their claims history. Call your payer rep for your area. Definitely say, hey, you know what, I want to see what my ICD-10 data would look like based on my claims history. That's something that will give you a jump start as to what your super bill may look like. That'll give you what your top reported codes would look like, going from 9 to 10. As we all know, there are a lot that are a one-to-one match in terms of 9 to 10, but there are a lot that are a one-to-many match. We still don't know which one you're going to get reimbursed on, still working through those issues, as well as what happens when you have a prior auth that has a date spanning, things like that. So the industry is still working towards those types of, or we're still working through discussing those issues, but these are some of the things that you can do now. Definitely request that ICD-10 report based on your claims history. So DuPage Medical Group. In doing a little bit of research, DuPage Medical Group definitely stood out to me, and here's why. So when they went to go purchase an EMR, they had a couple of things that they wanted to do within their practice because they were looking to overhaul to actually increase administrative efficiencies, pretty much overhauling their workflow within their practice. And they wanted to get a jump start on that now, not when ICD-10 comes, not when it's time to contract for ICD-10, but they wanted to find out what they could do to minimize manual rework now. So what they did was they actually looked at an EMR that provided easier access to a consistent medical record format, something that would be easy for their physicians to pretty much get accustomed to, that wasn't too different than what they were used to using. They wanted to reduce overall operational costs by streamlining patient records. They also wanted to recognize and gain workflow capabilities to improve practice processes. One thing that happens is, like I said, when you implement an IT system into your practice, you should reduce your manual rework and increase your administrative efficiencies. But the biggest thing that they did was they used their business intelligence, which is all that dashboarding to let you know how many claims that you have outstanding, how many claims are pending because of this reason, and just being able to give you the summary snapshots. They were able to collect their raw data and turn it into meaningful and actionable insight for decision making. That's the best thing that technology can do for you. So you want to make sure that when you're shopping for your practice management system or your EMR, that those systems are really doing those things for you to empower decision making. Because if you reduce manual rework here, you definitely can increase someplace else, and that's the goal. It's never to stop doing something and move on to doing something different. You want to find that balance and equilibrium within your practice. So what can providers do now? Fee schedule. That doesn't cost them a lot of money. Fee schedule. One of the things, believe it or not, I was at the AMA before I came on board with HealthIntel Architects. And one of the things with regards to fee schedule, and I'll be honest and say I learned a lot working at the AMA. But with regards to fee schedule, one of the things that you can do is how many of you would love to take an Excel spreadsheet, filter it through a system of logics and edits, and know where you're standing when you're done in less than 10 minutes? Actually less than 5 minutes, depending on how good you are. You can know what your specialty, you'll input your specialty, input your locality, and it'll take your data and see how you rank based on the services that you perform for that particular period of time and how you rank. Are you below Medicare? Are you above Medicare? And those are things that will help you to know. And how do you compare to other like specialties within your locality as well? That'll help to determine if you're an outlier or not. They have a product called AMA Path, actually, and it does exactly what I just stated. So that's something that you may want to take a look at. But you definitely want to analyze your fee schedule to make sure you're not an outlier. Contracting, you want to be able to use those analytic reports that you can get from your practice management system or your EMRs. And you want to be able to take that back to the payer and say, hey, look, I'm doing all these things great. This should filter or weigh heavily on the contracting terms. So those are other things that you can do now. I'll tell anyone, knowledge is power. The more information that you have to back up why you should be paid more, there's a possibility that you should try to do that. Your EMR vendors, like I said, you want to choose an EMR, practice management system vendor that actually is reducing manual processes or manual rework within your practice. Your billing clearinghouse vendor, you want to make sure that they're scrubbing that data for you on the front end to reduce adjustments, rejections, and denials on the back end coming from the payer. Claims reconciliation, the biggest one, claims adjustment and denial management, huge. I will tell any physician, invest in claims adjustment and denial management. You want to know what type of claims are coming back, why they're being adjusted, why they're being denied, and you want to build a trend on that. And not only do you want to build a trend on that, you want to make sure that going forward, the medical billers and coders know not to do X, Y, and Z, or to build this particular service for Aetna, build something different for United, build something different for Coventry. You want to know that they know exactly how to build the claim to get the services, to get the claim reimbursed. Claims reconciliation, like I said, you definitely want to find a system that allows you to automate that process, but that's something you definitely want to invest in. Patient satisfaction, as Mary Jo mentioned, why not send out a survey? SurveyMonkey is a free tool. Survey your patients, create a one-page flyer to ask them how was their service the last time they were in the office or before they leave. That's all ammunition to help you out with the business intelligence before the payer knows what's going on within your practice. RAC programs, you want to know if you're an outlier up front. You don't want to wait until they send you the letter in the mail or they're knocking on your door. There are things that you can do now to make sure that you're not an outlier based on the procedures that you perform for your specialty. Quality incentive programs, same thing. You have that information now. If you have any questions, anything, definitely email me. I'm always free to help physicians because that's pretty much, people always ask me, why did I leave the AMA? And it wasn't that I left the AMA just to be leaving the AMA. I left the AMA because I truly wanted to create applications and to truly help and advocate for physicians, but I wanted to be more hands-on. Other than a policy standpoint, I really wanted to be more hands-on and to really go after physicians and help them. So again, I thank you guys for having me, and I've enjoyed my time speaking with you, and I hope you guys have found this information very beneficial.
This concludes our program. Questions? Contact the TMA Knowledge Center at 1-800-880-7955. Thank you for using the TMA Distance Learning Center.